All right, so a warm welcome to all attendees from across the globe. So we are so pleased that so many of you have joined today. I've heard that we are more than 1,000 to that webinar, so that is a real event. So today's symposium, Menopause and Metabolic Syndrome, is led by the International Society of Endocrinology and is part of the International Menopause Society Women's Health Partnership Symposia series. This is a free initiative that is designed to expand healthcare professionals' access to world-class education on menopause and midlife women's health, featuring insights from leading global experts. So I'm Jean-Patrice Baillargeon, and I will be co-monitoring the symposium today. This is the agenda that we have planned for you today. And the webinar has been supported by an unrestricted grant from Bayer. Bayer has no role in the selection process of topics or speakers and has not vetted or reviewed the content of speakers' presentation. Some housekeeping features. So before we proceed with the instructions, you have to know that we encourage you to ask your question in the Q&A function. So you can see that on Zoom. You can ask question since the beginning. You don't have to wait to the end to pose your question. And you can also thumbs up a question that you think is interesting. So we will see which questions are the more requested and will help us with the Q&A session at the end. So at the end of the webinar, you also will be taken to a survey to claim your certificate of participation. And lastly, the recording of this and the previous symposium in the series, What's Hot? Options for Treatment of Hot Flushes 2025 will be shortly available on the ISE Global Education Hub, where you can also claim CME and CPD credits. So I'm Jean-Patrice Baillargeon. I'm a professor of medicine at l'Université de Sherbrooke. I'm also endocrinologist at the Centre Hospitalier Universitaire de Sherbrooke and clinical investigator at the Research Center of the Centre Hospitalier Universitaire de Sherbrooke. My area of expertise include reproductive endocrinology, obesity, polycystic ovary syndrome, lifestyle intervention, and research methodology. And I am on the board and the education working group of the International Society of Endocrinology. And it is really my great pleasure to co-chair this session with Dr. Matthew Nudi. Matthew, you can introduce yourself.
Yep. Hi, my name's Matthew Nudi. I'm from the Education Committee of the International Menopause Society. I'm also a cardiologist at the Penn State Hershey Medical Center in the United States. I have both a research and clinical interest in cardiovascular disease prevention in women, and I am excited to serve as a co-moderator for today's session. Thank you.
Thank you, Nudi. And we will have, I'm sure, a very nice session and very interesting Q&A discussion at the end. And we are really honored to have two esteemed speakers with us today. So the first speaker is Dr. Panagiotis Anagnostis, who is from the Aristotle University of Thessaloniki in Greece, and who will be speaking about changes in body composition and cardiometabolic risk factors during the menopausal transition. Dr. Anagnostis is Assistant Professor of Internal Medicine. He has received many awards, including the 2024 Henry Berger Award from the International Menopause Society, and he has been listed among the top 2% of scientists worldwide by the Stanford University from years 2022 up to years 2024. So we are very glad to have Dr. Anagnostis with us, and we also have Professor Samar R. El-Kudari. So Professor El-Kudari is from the School of Public Health, University of Pittsburgh, and she will be speaking on menopause and cardiovascular risk, unraveling the link and exploring opportunities for early intervention. Dr. El Kudari is a vice chair for education and professor of epidemiology and clinical and translational science at the University of Pittsburgh. She has received many awards, including the Menopause Society New Investigator Awards and the Endocrine Society Early Investigator Award. And her work has been seminal to advance work in women's cardiovascular epidemiology, resulting in sharing the first American Heart Association scientific statement on menopause and cardiovascular disease, among other achievements. So thank you very much for being here to this symposium. We will start without further delay. I will ask Dr. Anagnostis to start off. So you have the virtual floor, Professor Anagnostis. Go on.
Okay. Can you hear me, first of all? Because, okay.
We can hear you.
Yes, I'll start my video. Okay, let me share my screen. Is it clear? Yeah?
Yes.
Yes. Okay. So, okay. Dear Chairman, thank you very much for your kind introduction. Dear colleagues, first of all, I would like to thank the International Menopause Society and the International Society of Endocrinology for this honorable and very kind invitation. In the next 20 minutes, we'll discuss about the changes in body composition and cardiometabolic risk factors which occur during the menopausal transition. This is my conflict of interest statement. None of these has to do with the purpose of this presentation. So we actually need to address three issues according to this presentation. First of all, what is the effect of the transition to menopause on body fat composition and body weight? Second, what is the effect of transition to menopause on cardiovascular risk factors? And some words about the effect of menopausal hormone therapy on body fat composition and cardiovascular risk. With regard to the first question, it has been clearly shown by observational studies that postmenopausal women have about 36% higher thoracic fat and about 49% greater intra-abdominal fat region compared with premenopausal women of the same age. These differences are independent of age and fat mass. The main participant, the key factor for this body fat distribution is the increase in visceral adipose tissue, which increases from 5 to 8% initially to 15 to 20% in the postmenopausal state. This is translated into about 12 pounds, that is 5.4 kilograms within 8 years since the onset of menopause on average. These alterations occur 2 years before the final menstrual period and account of about 8.2% per year increase in VAT, and 2 years after the final menstrual period, that is 5.8% per year increase in visceral adipose fat tissue. This is associated with increased cardiometabolic risk, and an example is that it has been estimated that about 20% increase in VAT is associated with at least 2% increase in intima media thickness of the internal carotid artery. All these changes have to do with the decline in estrogen levels, of course, and looking into the pathogenetic basis, this decline leads to decreased basal metabolic and energy depend without an increase in food intake, which is very characteristic. And this has to do with lower lipid oxidation and lipoprotein lipase activity. And of course, it is combined with reduced physical activity. The loss of estrogen, the decline of estrogen also leads to a loss of activation of the estrogen receptor alpha in hypothalamus, leading to reduced ability of the sympathetic nervous system to regulate adipose tissue distribution, leading to visceral fat accumulation, and of course, increased insulin resistance. Of course, we must take into account the decrease in lean body mass, which again leads independently to increased insulin resistance. Except for the decline of estrogen, menopause is also characterized by a state of a relative androgen excess, because there is no change in androgen production after menopause, and combined with the abrupt decline of estrogen production, this is translated into an increased androgen to estrogen ratio. If we take into account the decline in SHBG due to aging to central adiposity, this leads to increased bioavailable androgen into the circulation. So all this leads to a state of relative androgen excess, which also contributes to the redistribution of body fat to the central body region. So visceral adiposity increases, lean body mass decreases during and after transition to menopause, which has the pathogenetic basis of decreased basal metabolism, decreased energy expenditure, and combined with decreased physical activity, which leads to muscle atrophy and decreased lean body mass. This leads to increased insulin resistance. Of course, except for estrogen, the relative androgen to estrogen ratio, the relative androgen excess, also contributes to this body fat redistribution. What about the other risk factors, except for abdominal obesity? We all know that estrogen receptors are expressed in the liver, and this contributes to decreased gluconeogenesis. They are also expressed in fatty tissue and muscles, leading to increased glucose consumption, and into the beta cells of the pancreas, which are associated with increased insulin secretion. All these physiological mechanisms are reversed after transition to menopause, that is, increased gluconeogenesis, decreased glucose consumption, and decreased insulin secretion, which leads to a dysregulation of glucose homeostasis, mainly impaired glucose tolerance, first, and second, impaired glucose decreased insulin production. And what is seen is an increase in impaired glucose tolerance of about 6% per year. But does transition to menopause really predisposes to higher diabetes risk? This was clearly shown in the subpopulation of early menopause and premature ovarian insufficiency, which accounts for about 10% of the general postmenopausal population, and premature ovarian insufficiency is about 1 to 3%. So with this systematic review and meta-analysis, we clearly showed 6 years ago that transition to menopause, if it happens before the age of 45 years, is associated with 12% increased risk of type 2 diabetes, and it is more evident in women with POI, leading to 1.5%, 1.5 fold, that is 53% relative risk increase in the incidence of type 2 diabetes. So early menopause and POI are associated with increased risk of type 2 diabetes. These results were verified, were replicated in later studies, such as the E3N study, which showed this inverse association between age of menopause and type 2 diabetes incidence. You can see that if women enter menopause before the age of 45 and the age of 40, there is about 1.3 to 1.4 increased risk, almost what we show with our meta-analysis, and this is decreased if the age of menopause increases. Bilateral ovarectomy leads to about 57% increased risk of type 2 diabetes. That means that surgical menopause really matters, because it further increases the risk of type 2 diabetes. And if we see this issue from another point of view, that is the reproductive lifespan, if it is shorter than 40 years, judging by the data provided by WHI, so shorter reproductive lifespan leads to a 37% increased risk of type 2 diabetes compared with the, let's say, normal type 2 normal reproductive lifespan, that is longer than 36 years. What about the other risk factors? Let's discuss about blood pressure. Blood pressure increases with age. It is well known due to vascular elasticity and due to atherosclerosis. but there is a steeper increase in systolic blood pressure in women compared with their male counterparts. Again, the relative increase of androgen compared to estrogen leads to increased endothelin and angiotensinogen levels. These factors contribute, of course, to arterial hypertension. Another cofactor is the salt sensitivity and sympathetic activity, which is higher in postmenopausal compared with premenopausal women. And again, we searched in the subpopulation of early menopause and POI with regard to arterial hypertension, and we showed that in premature menopause, there is a 10% increased risk of arterial hypertension. This was marginally not significant for POI, perhaps due to the effect of estrogen, but we must take it into account. But what is of utmost importance, except for the abdominal obesity, the type 2 diabetes risk, the arterial hypertension risk, is the transition to a more atherogenic lipid profile. As women age, as women enter menopause, there is a gradual increase in total cholesterol, in LDL cholesterol, in triglycerides, which converge to the levels seen in men of the same age, and in some cases they exceed these levels. If we also look into the levels of apolipoprotein, such as ApoB, which is an independent risk factor for cardiovascular disease, it is higher in postmenopausal compared with premenopausal women, as we show 10 years ago from studies from the UK. And some indexes, such as the ApoB to ApoA1 ratio and the LDL to ApoB, which means higher cholesterol component. And there is also a decrease in HDL. And another factor that seems also to be influenced by transition to menopause, as we showed in another meta-analysis, there is an increase in Lp(a) after transition to menopause of about 4 milligrams per deciliter, although it has to do mainly with age rather than to the menopause per se. But Lp(a) should be measured after transition to menopause because this leads to an increase compared to the premenopausal state. Taking all these things together, you can see here in this table that total cholesterol, LDL cholesterol increases, the triglycerides increase, HDL decreases, mainly the HDL2 compartment. Lp(a) is also increased, apolipoprotein B is also increased, fasting blood glucose, insulin resistance, type 2 diabetes risk may increase, although there is no an independent effect of menopause per se in the general population. Rather, it has to do with early menopause. But of course, in predisposed individuals, transition to menopause really matters on this regard. Blood pressure may also increase, and of course, as we mentioned, BMI increases, and this has to do with visceral adiposity. But is there indeed an independent association between menopause per se and increased risk of cardiovascular risk? Some older studies, such as the Framingham and other studies, did not clearly show that there is an independent effect of transition to menopause on the risk of cardiovascular events. However, this has been clearly shown in women, again, with POI and premature menopause, showing an about 1.5 increased risk of total and cardiovascular mortality. Both these meta-analyses in 2016 have confirmed this finding, and another meta-analysis in 2016 showing that early menopause is also associated with increased risk of cardiovascular mortality by 50% increased risk. It has to do with coronary heart disease, not with stroke risk. And these findings have also been replicated by the large cohort study by the UK Biobank, which enrolled more than 140,000 postmenopausal women, showing that in fully adjusted models, there was almost a double risk, especially for surgical premature menopause, for the first cardiovascular disease, for coronary heart disease, for heart failure, aortic stenosis, mitral regurgitation, and venous thromboembolism. So, menopausal transition increases insulin resistance and gluconeogenesis, decreases insulin secretion, and increases blood pressure. The main component of this increased cardiovascular risk is the atherogenic dyslipidemia that postmenopausal women are characterized with compared with their premenopausal counterparts. But whether menopause per se is an independent risk factor, it has not been proven. But it has been proven for POI and early menopause. With regard to the third question, whether menopausal hormone therapy provides a beneficial effect on these findings, it has been shown by several studies, such as this in 1997 by Espeland et al., showing that the expected increase in weight and waist circumference, that is about 2 kilograms and 3 centimeters, is less if women receive postmenopausal menopausal hormone therapy, either unopposed conjugated estrogen or combined with MPA. You can see here that there is a gradual increase in weight change, whereas the expected increase is less with menopausal hormone therapy, mainly for waist circumference. This has also been shown in another studies. As you can see here, the expected increase with HRT with MHT actually is about 2 kilograms, whereas it is higher if women do not receive menopausal hormone therapy. It has to do with fat mass and trunk fat, as you can see here. And this was also shown in another study, showing actually that there was no difference between transdermal or oral estrogen with regard to the weight gain. That was 2.7 and 1.5. Whereas if they did not receive any estrogen, this increase was about 6 centimeters in waist circumference. This has to do with a significant decrease in visceral adiposity, in BMI and android fat distribution. There was no benefit on lean body mass, and these findings seem not to be preserved in past users. As you can see here, in current users, there was a decrease in the android fat, whereas in past users, the respective benefit was lost after the discontinuation of MHT, whereas in no users, there was a gradual increase in android fat as shown. There is also a beneficial effect on glucose homeostasis, fasting glucose, fasting insulin, increasing insulin sensitivity and glucose disposal, and an increase in insulin secretion. This has been shown in several studies, such as this meta-analysis in 2006, showing a decrease in type 2 diabetes by about 30%. There was also a benefit in women with diabetes that showed that MHT reduces the incidence of HOMA-IR by 35% and fasting glucose by 11%. We also performed international umbrella review and meta-analysis showing that indeed the risk of type 2 diabetes was reduced by about 30% with MHT. You can see also the data by the WHO study showing the absolute risk reduction of 5 less cases with type 2 diabetes in women who received MHT, and this was also shown with 13 cases fewer with estrogen monotherapy. Oral estrogen seems to decrease insulin resistance more than transdermal. This was also shown in the FRES 3N study, were showing a greater reduction in the risk of type 2 diabetes with oral estrogen. These effects seem to be dose dependent and they are lost after stopping MHT. Progesterone seems to play a role because if it is MPA, seems to blunt the beneficial effect of estrogen, whereas if it is natural progesterone and androgesterone, these are neutral, so we must prefer the natural progesterone. Lipids may also be favored by MHT, since there is a slight but significant decrease in total cholesterol and LDL cholesterol and an increase with HDL, whereas triglycerides may rise with oral estrogen. LPA may also decrease, especially with oral estrogen. Again, Medroxyprogesterone and norethistérone should not be preferred because they may have an unfavorable effect on lipid levels. And all these combined here in this chart, in this table, you can see the decreases in total LDL cholesterol, increases in HDL, decreases in Lp(a). Triglycerides may increase with oral, but there is no effect with transdermal. Waist circumference and visceral adiposity may decrease. There is actually no effect on systolic blood pressure, and there is a beneficial effect on type 2 diabetes risk. Finally, MHT may reduce cardiovascular morbidity and mortality if it is initiated in women who are younger than 60 years of age or during their first 10 years after the final menstrual period. However, we should not prescribe MHT for the sole purpose of cardiovascular risk reduction, but it should be administered, except for contraindications, in women with POI and early menopause, irrespective of vasomotor symptoms, because HRT actually reduces the risk of cardiovascular disease. So to conclude, transition to menopause may increase type 2 diabetes risk due to an increased risk of abdominal obesity, visceral adipose tissue, insulin resistance, and decrease insulin secretion. It is also associated with atherogenic dyslipidemia and increase in blood pressure. MHT seems to be beneficial since it reduces visceral adiposity and the risk of type 2 diabetes. This is more evident with oral estrogen, except for triglyceride levels. Natural progesterone and dydrogesterone are the preferred progestogens, and we must take into account that MHT reduces the risk of cardiovascular disease if it is initiated early, that is in women younger than 60 years, and of course in women with premature ovarian insufficiency and early menopause. However, we must underscore that MHT is not indicated for the sole purpose of cardiovascular risk reduction. And with all this data, the slides, I would like to thank you very much for your kind attention.
All right, thank you for that excellent presentation. We're now going to move to the second presentation of the webinar. So Professor El-Kadari will be presenting Menopause and Cardiovascular Risk, Unraveling the Link and Exploring Opportunities for Early Intervention.
Thank you so much for having me today. I really appreciate the opportunity to talk about this topic, which has been really seminal in my research that I have been doing. I want to make sure that you are seeing the presentation mode of my presentation.
Yes, it's perfect.
Good. Okay, yes, today I will be talking about menopause and cardiovascular risk, and I will be mainly focusing on shedding light more on what kind of menopause characteristics has been linked to cardiovascular risk and talking about opportunities for early intervention. I have nothing to disclose. My learning outcomes for this presentation. Number one, I would like the audience to understand how menopause factors contribute to increased cardiovascular risk. Then we will focus on taking some time to recognize midlife as a critical period for optimizing lifestyle to reduce cardiovascular risk. And finally, I will be reviewing current research on lifestyle approaches. So in the literature, several menopause characteristics has been linked to increased cardiovascular risk, and I want to focus mainly on those four. So timing of menopause is an obvious one. Endogenous hormones such as anti-Mullerian hormone, estradiol, and FSH, but because of the limitation in time, I will be just focusing on estradiol. Menopause symptoms, many, but I will be focusing on vasomotor symptoms and insomnia or sleep disturbance. And finally, stage of menopause, where I will be spending some time talking about perimenopause in particular. So as you just heard from Dr. Anna Gnostis, timing of menopause is critical, and this is really the mostly studied menopause characteristic that has been linked to cardiovascular risk. Meta-analysis and systematic review have clearly shown that being premature menopause or have early menopause as defined by less than 45 years at menopause associated with a risk that range between 36 to 50%. These robust findings about premature menopause led the American Heart Association as well as the American College of Cardiology to acknowledge premature menopause as a risk-enhancing factor when evaluating risk for cardiovascular disease in women. What factors can actually predict premature menopause? Being Black or Hispanic, also having shorter cycle length, less than 26. Nulliparous or low parity would predict having premature menopause. Smoking is a big risk factor, and being underweight. It is important also to acknowledge that there is a significant genetic relationship for age at menopause. Also, I want to highlight that this association actually is bidirectional association. So it's mean that not only younger age at menopause predict higher risk of cardiovascular disease, but having, a high risk of cardiovascular disease early in life can actually predict younger age at menopause. Shifting gear to hormones as the second really characteristic of the menopause transition linked to cardiovascular risk, and I'm focusing here on estradiol. I have to say that the literature has been very limited and mainly cross-sectional in design, focusing on postmenopausal women and measuring estradiol just one time point using low sensitivity methods. The findings that I will be presenting mostly during this presentation will come from the study of women's health across the nation, the SWAN study. This is by far the largest study of the menopause transition in the US, has been running since 1996, including 3,302 women. In this study, we were able to measure estradiol when women were at their 40s up to now when they are at their 70s. So we have really very, very comprehensive measures of these hormones. We were able to use what we call the group-based trajectory modeling. That's a very interesting method, enable you to cluster women based on how they could experience change in their estradiol. You can see here that we were able actually to show 4 different patterns of change in estradiol as women transition through menopause. Interestingly, 45% of the women may experience a rise in their estradiol before a steep decline, and the rest of women would have either the low flat or the low decline. We also looked at how these groups differ or predict subclinical measure of atherosclerosis, and here we focus on carotid plaque. Interestingly, you can see that the group that have the rise before menopause, the green one, actually have the lower risk for carotid plaque, supporting protection effect as long as you have this estradiol early before the transition. Cycle length is another characteristic that has been of interest, and to the left of the slide, you can see different patterns of cycle length as women transition through menopause. Surprisingly to us, when we run this analysis, we found that 62% of our women actually experience a flat pattern of cycle length, no change till the time of menopause, but almost 16% experience a rise as early as I would say 5.5 years before menopause, and the rest of the women experience a late rise as early as 2 years before menopause. We also looked at how these related to subclinical measure of atherosclerosis. Interestingly, the group that has the late increase in their cycle length is the group that show the lowest measure of carotid intima media thickness, which is a subclinical measure of atherosclerosis, while the group group that has the stable, as well as the early increase show actually the greater risk for the subclinical measure of atherosclerosis. Shifting gears to menopause symptoms, vasomotor symptoms is the main, I would say, hallmark of menopause, with almost 80% of the women experience hot flashes and night sweat. And within the study of women's health across the nation, we were able to identify or determine that women actually are not the same when they experience these symptoms. And you can see here in the left part of the slide, we have 24% of the women experience, a high frequency of vasomotor symptoms during the transition. This is what we call the super flasher. We have those who experience a late onset, and those who experience an early onset, and those who are lucky, who really experience just a very minimal vasomotor symptoms around the final menstrual period. Being black predict, having a high frequency of vasomotor symptoms, as well as BMI, an increase in body weight. Then we have been really looking at whether these symptoms are benign, and the research has been showing a strong link between symptoms and cardiovascular disease risk. To the left of the slide, the 4 groups I just showed you, we looked at its relationship with intima media thickness. Those who have the high frequency or the early onset are the one who have the thickest intima media thickness. And here we looked at the frequency of vasomotor symptoms in relation to cardiovascular events. And as you can see, we showed a dose-response relationship. The higher the frequency of vasomotor symptoms, the greater the risk of cardiovascular disease later in life. Menopause symptoms also include, sleep issues. Women experience, this during the transition. And to the left, we classify women into 4 different potential patterns. We have 22.6% of the women who could experience insomnia symptoms persistent and a high level over the transition. There is a group who experience an increasing pattern, a group who stay stable up to certain time, and then there is a decline, and a group who have just a low level of insomnia. And then we looked at the relationship of these groups with cardiovascular events, and interestingly, as you can see, there's a dose response relationship where you can see that persistent insomnia symptoms over midlife found to be associated with a greater risk of cardiovascular disease in women. The 4th characteristic of the menopause transition is the menopause stage, where women in the transition. And perimenopause is really a very unique period of women's life. This is literally means the time around menopause. And studies have showed that perimenopause can be as short as few months and as long as a decade. But the mean time of menopause would be 3 to 4 years usually. And during this time, as you have heard from the first presentation, women experience many changes, multiple changes. And I just share here findings from the SWAN study, all supporting, changes happening around, 2 to 2 years around the final menstrual period, whether we are talking about metabolic syndrome, visceral adiposity, as you heard, fat and lean mass, structural and functional changes in the vasculature, systolic blood pressure. I would just want to spend some time with HDL because, in our work, we have actually seen that HDL-C increase in women as transition through menopause over 25 years of data showing that it's not going down. And we actually have more funding to dive deep into this. And we looked at the HDL cholesterol efflux capacity. That's the ability of the HDL particle to remove the cholesterol from the periphery. Interestingly, irrespective of the increase in HDL-C over the transition, actually the ability of this particle to remove the cholesterol from the periphery decline, suggesting a dysfunctionality in this HDL as women transition through menopause. So between the first presentation and what I just highlight here, it's clear that the menopause transition has been linked to adverse changes that are critical to heart health. And we know that it's critical to heart health because, that's how we measure heart health at the moment here, based on the American Heart Association. There is what we call the Life Essential 8. That's a new metric introduced by the American Heart Association that include 4 risk factors and 4 behavioral factors. The risk factors are blood pressure, blood lipid, body weights, and blood sugar. I believe you have heard between the first presentation and this presentation that women, as they transition through menopause, experience issues in those 4. And then when we look at the behavioral factor, those are smoking, sleep, diet, and physical activity. I showed you some data on sleep. There are data on the data on diet and physical activity, I would say limited. But when we looked at these factors within the study of women's health across the nation, and we classified, women, whether they were poor, adherent to the limit identified as healthy or intermediate or ideal, you can see that 80% of the women do well for glucose. But when you look at cholesterol, blood pressure, BMI, we are talking about 50 to 40%. But interestingly, only 18% of midlife women in our cohort actually evaluated had 5 to 6 of these at the ideal components. So this is actually alarming and telling us that we need to do more about this. I think, what was shocking for us that none of the women actually classified as ideal for diet. Most of them classified as poor for diet and poor for physical activity. Usually when I present this data, I like to remind everyone of the data coming from or came from the Nurse Health Study, which is really a very large study that include 84,000 nurses and followed them over 14 years of follow-up. In this study, they looked at the relationship between adherence to lifestyle, healthy lifestyle, defined as, underneath this figure, no smoking, BMI less than 25, consume at least half a drink of alcoholic beverage, moderate, vigorous physical activity, and being on a diet that's rich in cereal, fiber, marine and 3 fatty acids, and low in trans fat. When they looked at those groups, they found that if you are able to stick to this, we can actually prevent 74% to 82% of coronary heart disease and stroke event. This is amazing. So we really have something in hand that can help and can prevent future event. But what again, disappointing is that only 3% of the study population adhere to these multiple healthy lifestyle. And when I looked at the national data showed that also only 20% of the female over than 20 years old have more than 5 healthy lifestyle metrics. So we have something in hand that we know it can prevent and can, help us reduce events. But I believe the implementation, the ability to apply this, I believe is really the problem that we are facing at the moment. This is really also an interesting data coming from the Chicago Heart Study, which include huge data, 25,000 men and women between the age of 18 to 74, followed for over 40 years since baseline. And what they did here, they looked at cardiovascular health in every single person in the study, and they defined that cardiovascular health based on blood pressure, cholesterol, diabetes mellitus, BMI, and smoking into favorable, elevated but not high or high. And then they classify the participant whether they all have favorable for these factors, or 1 elevated, 1 high, or 2 high. And as you can see, they looked at the relationship between this and all-cause morbidity and all-cause morbidity and cardiovascular mortality. And you can see clearly that having, at least 2 of these high would result in a significant increase in risk for, all-cause morbidity as well as cardiovascular mortality. This study also showed that favorable cardiovascular health at younger age could actually extend survival by almost 4 years. So we are talking about a very important period of life that if we act on it, we can actually reach healthy aging, and we are able, to postpone the onset of all cause and cardiovascular morbidity between 4.5 to 7 years. This is really amazing and promising for sure. So the accumulated finding on the menopause transition and cardiovascular disease pushed for publishing the first scientific statement on this topic. This is really a comprehensive statement covering a lot of what we presented today, as well as also summarizing hormone therapy effect on the menopause transition, covering statin and aspirin. So that should be a good reference for anyone who want to read more about this topic. But within this scientific statement, we also focus on trying to understand what studies exist for us related to lifestyle change during the menopause transition, and whether it's actually could postpone all the changes that women experience during the transition. Unfortunately, I would say till yesterday night, I was looking at PubMed trying to find trials. The trials are very limited in a perspective related to the size of the participant, no more than 100, and also the sporadic, approach in approaching women. Most of the studies focus on postmenopause, very, very limited focus on the perimenopause, which is the time when women experience all the changes that we described today. This is one unique study that was conducted in Pittsburgh. It's the Women's Healthy Lifestyle Project that include the largest, I would say, I could find really, number of participants, 535 healthy premenopausal women who were not on hormone therapy. Those actually followed for 5 years. They randomized into lifestyle and behavioral intervention with a control. And then the study actually showed significant decline in weight. So it showed that we can actually reverse weight gain, we can reverse weight circumferences increase, as well as the increase in in low density lipoprotein that increase over the transition. It is important also to highlight that well-being matter. In this analysis, we actually looked at the relationship between well-being and coronary artery calcification in women transition through menopause, and we found that well-being can actually reduce the risk even if you have cardiovascular risk factor high in those women, supporting that we should have a holistic preventive approach to cardiovascular events when we talk about midlife women. So to summarize, menopause matter for women's cardiovascular health. Early and premature menopause are now risk enhancing factor for cardiovascular risk assessment. Midlife women experience acceleration and adverse changes in multiple metrics related to heart health. Perimenopause is a stage of vulnerability. That's how I like to call it in terms of cardiovascular disease risk. And midlife women should really strive for a healthy heart, for a heart healthy lifestyle in order to counteract what the menopause consequences that they experience. I believe healthcare provider should be aware that when they see a midlife woman, this woman could experience all those changes. So they should, assess those changes and see if the woman may be, eligible for some of the prevention medication. And here, this is really a very interesting, suggested approach of that prescribing statin. And you can see, the authors in this paper actually include the premature menopause as a risk-enhancing factor in your decision when you prescribe statin for, primary prevention or secondary prevention for women. The American Heart Association now have really a very good website that focus on women and menopause, provide instruction for women, what to do before menopause, during menopause transition, and after menopause, what kind of healthy lifestyle they have to follow. This is really a very good infographics you may want to have handle to your patients, give them a very good education about, the transition, what changes women experience, and how they can take care of their heart. This is also a unique work that was published in Europe, coming as a consensus document from the European cardiologist and gynecologist. And it's not just only focused on menopause, it also focuses on other women-specific risk factor, but provide, a clear guidance on, the lifestyle changes that women need to follow and need to encourage to apply. With that, I would like to acknowledge all my co-authors and collaborators, the students I have been working with, as well as women who contributed to the understanding of this topic, advance really the science. And this is the funding resource I have. And this is really the School of Public Health. If you come to visit Pittsburgh, there is a giant building here really covering the sky. But thank you so much for listening. And I will be happy to answer a question in the Q&A session. Thank you so much.
Thank you very much. So thank you to both speakers. So we have learned that there is a lot that is happening during the menopause transition, and there's the role of many factors. We have received a lot of questions, in fact, in the Q&A panel. So maybe I can start, and we can alternate with Matthew and I. There is a lot of questions regarding treatment as well. And so you have mentioned the role of estrogen, you have mentioned the role of lifestyle, also the role of flashes, well-being, sleep. So what would be your opinion regarding the best approach? So estrogen, hormonal therapy seems to be important, lifestyle, but also there's these new drugs targeting flashes, non-hormonal medications. So maybe they might help because they would also target that risk factor. So what do you think?
Should I speak or Professor?
Yeah, you can start, Dr. Professor Agnesis.
Yes, actually, thank you very much for your contribution to this panel and for the questions. Actually, with regard to the first question, and of course it has to do with your approach, yes, estrogen, of course, plays a pivotal role in the management of all these symptoms, provided that there are no contraindications. As I mentioned, estrogen may ameliorate most of these factors contributing to cardiovascular risk. It does not reduce cardiovascular risk except for the cases of premature ovarian insufficiency, early menopause, and women entering menopause at an age younger than 60 years or during the first 10 years. Thereafter, there is no benefit. So with regard to the, yes, and of course, we should take into account all this data that Professor Kudari provided with regard to lifestyle. Of course, lifestyle intervention and exercise is the cornerstone of treatment and of approach. But of course, we should not we should provide this opportunity to these women who have indications. We should not be afraid of the risk of breast cancer, since it is quite low in general, but we can calculate. So with regard to the first question, if HRT decreases insulin, yes, it did decreases insulin resistance, and it can also decrease the risk of type 2 diabetes by about 30%. Of course, this benefit is lost after MHT discontinuations. Can I answer to the second question? Can I proceed to the second question, or would you like to make a comment?
Yeah, we will choose the questions, and so you can Matthew and I will give you the question that we would like to discuss. So maybe Professor El Kudari, if you have comments on the treatment. So is estrogen enough for those who cannot have estrogen? Do you think that treatment with non-hormonal therapies such as the neurokinin B receptor antagonist, do you think there's any place for those drugs because they would help all flashes and well-being and sleep? What's your opinion?
Yeah, I think this is excellent question, and I wanna just make sure, when we talk about estrogen, really we are talking about estrogen to treat vasomotor symptoms and to treat symptoms, and we are not talking about estrogen to prevent cardiovascular disease. Per current recommendation, hormone therapy are not recommended to prevent cardiovascular disease. However, it's the gold standard treatment for vasomotor symptoms. So, as Dr. Anna Gnostis said, that if you have someone who have hot flashes and they are younger than 60 or within 10 years of menopause, it is advisable to let them know that this hormone therapy would help them and would elevate their symptoms, and at the same time they would get beneficial effects on their cardiovascular system. Related to the new non-hormonal medication, this is really a very interesting question from a research perspective that I and my group would love to pursue. I don't think there is a data looking at whether taking this medication would actually elevate some of the cardiovascular risk factor, like, for example, lipids or insulin resistance, because, if we, for example, hypothesizing that the symptoms is linked to cardiovascular risk, then whether if you elevate the symptoms, cardiovascular go down, that's a very interesting question. But again, it put us as an epidemiologist in the causal kind of relationship, which would require, of course, a clinical trial to be able to answer. But I'm expecting that this question will be answered in the future for sure.
Can I add
Thank-
something now?
Yes, go ahead.
Yes, I totally agree. I must contribute to our conversation with some data provided by our group with regard to the severity of vasomotor symptoms. That means if women experience severe symptoms, they are at high risk for cardiovascular disease, especially if they are younger than 60 years, and at high risk of developing osteoporosis. The severity may has to do with the fluctuations of the estrogen levels, which may impair the endothelial function. So it's not the symptom per se, it's just the underlying pathology. That means that these women may indeed benefit from estrogen therapy.
Other question, Matthew? Do you have other question to ask from?
Yeah. So there is a question here in the chat about some of the newer anti-obesity medications and if they may have a role in menopausal women who experience redistribution of fat mass. Any comments on that?
You want?
I can start. I think this is again, the audience really hit on new research questions on the field that all of us interested in. Yes, the GLP-1 are really interesting, and I know of some groups in the US are now working on this, where they are trying to look if they prescribe GLP-1 in perimenopause women. Are they able, for example, to counteract the increase that happened during the transition? So that's part of the question. I think the other part that we will need still time to figure it out, whether the decline that we will approach by GLP-1 would actually prevent cardiovascular disease later in life. So that's definitely, would require more of a prospective studies. But, I am not aware of any publication at the moment related to this. However, I believe that this is an approach that I have been hearing a lot, and I know that there are a couple of studies at the moment trying this.
Thank you. And maybe another question is regarding the diagnosis criteria of metabolic syndrome, or even dyslipidemia, or the indication of a treatment such as statin. So you mentioned that in your slide. So is there any difference we should make in women with in perimenopausal or menopausal transition? Should we use different criteria or be more aggressive for statin therapy, for example? What would be your comment about that?
Is that the question for me, right?
Yeah, I mean both of you, but you can start, Professor.
Okay, I think I will start by saying, the metabolic syndrome, as you know, it's a 5 criteria, 3 of those 5, right? Now, from our work, at least one of those criteria is HDLC, right? And I kind of touch base on HDLC, saying that, you know, HDLC in our cohort has been actually showing that it's increasing. And, you know, our work has showed that HDL actually could become dysfunctional. So from my view, at least, some of the factors that we are using to classify metabolic syndrome may not be applied to postmenopausal women as to premenopausal women. That's, for example, for HDL-C. Now, blood pressure is another factor, and I did not present this data, but there is a very interesting data came out 2 years ago showing that blood pressure, women actually at a lower level of blood pressure can experience the same risk for cardiovascular disease as men who have to have blood pressure at a higher level. So if you are talking about 140 systolic blood pressure, give you a hazard ratio of 1.3, women would reach this hazard ratio with a systolic blood pressure at 110. So this is suggesting that we actually need to think about cut point for blood pressure for women as compared to men. And this is really, you know, again, pointing out, you know, maybe we should think about, you know, have a different definition. But I would say in order to be there, you know, we cannot go there without more research to support, you know, these decisions. But definitely the data we have in hand supporting that, we have to think about sex-specific definitions when it's come to men versus women.
Any comment, Professor Anagnostis?
Yes, I actually agree with Professor Kunderi. I must comment that we should not actually medicalize menopause. Menopause is not a kind of disease, except for premature ovarian insufficiency and premature menopause. We should not actually consider this as a unique disease or a unique syndrome. We should take into account all these alterations with regard to body fat distribution and cardiovascular risk profile, which aggravates as women enter menopause, just to enhance our holistic approach, not to pay attention only on a unique parameter. Metabolic syndrome should not be, at the moment, considered as a specific entity for menopause, although menopause leads to increased risk of metabolic syndrome. So medicalization is not of my concept of view. I don't support this. We just try to provide this data in order to make our colleagues to be more familiarized with all these alterations and to enhance their general and their clinical approach, okay, to use statins or whatever, and of course to discriminate this unique subpopulation of premature menopause and premature ovarian insufficiency.
Thank you. Matthew, do you have maybe a last question before we end the session, because it's already by the hour?
Yeah, sure. I'll ask one last question here. So there was a question about the use of statins during the menopause transition, and specifically commenting on a potential increase in the risk of diabetes with statin use. Should there be any reservations for using a statin in a menopausal woman who's already at a higher risk for diabetes?
I would start by, you know, saying I'm not a clinician, so that's very important. So I'm not prescribing medication, but I will give my opinion from, you know, research I have been looking at. Use of statin has a specific guidelines. We cannot use a statin just because we know that, for example, women during the transition experience a rise in their LDL. Now, they need to have a limit, you know, that would allow them to be on statin in particular. So definitely I see, you know, prescribing statin to women during the transition would need to be guided by, you know, the level that is permitting them to be on statin. And then, you know, it's a balance. It's really a balance between, you know, benefit and risk. And it's a discussion between the patient and their physician. But I would like to emphasize the lifestyle. Again, I want to bring it, you know, into the top, because it's really effective and it can help. And you know, if we are able to focus on advising women and making them aware that you can achieve something by focusing on your lifestyle, you know, as long as you are not, you know, at high risk per risk equation, I feel like should be the first line really of intervention for perimenopausal women. I agree with Dr. Anagdasis that we don't want to medicalize, you know, menopause. It's a stage of women's life. We are trying to counteract those, you know, changes, you know, in order to help them live a healthy life in the future.
All right, so I think we are. Dr. Anagdosis, another comment?
Yes.
Final comment.
Studies may indeed increase the risk of type 2 diabetes, but it is quite low. It has been estimated that we can prevent about 300 myocardial infarctions in order to cause one case of diabetes. So we should not be so much afraid. The effect is dose dependent, and it can be differentiated by the type of statin. For example, pitavastatin has a neutral effect on type 2 diabetes risk. So again, LDL is the main target. We should follow the European or American guidelines, first of all, to reach the optimal target, and afterwards, if the patient is at high risk of diabetes, or if he develops or he or she develops diabetes, we should optimize our treatment either with lifestyle or with the well-known anti-diabetic medication. So do not be afraid of type 2 diabetes risk with statins. It is quite low.
All right, thank you very much. We still have a lot of questions, but we have to put that into an end to close the session. So thank you very much, both speakers. I think you've made the point that the menopausal transition is an important period with a lot of change, increasing risks. We have to be aware of that, look at the risk, and it's an opportunity, in fact, to take in charge these women and help them to go through that period and decrease their risk in long term. And I agree that lifestyle should be the first approach, but we know also that treating symptoms and estrogen therapy might be helpful in many of those women. So thank you very much. And the session has been recorded, so all participants, you can look at it again. There's a lot of material there, and you can also get your credits after the sessions. So thank you very much. Bye-bye.
It was our pleasure to be here.
Thank you so much. Thank you.